Hi all, my name's Ben Desborough. I'm Associate Professor here at Griffith University, and in this session we're going to be talking to you about anthropometry. This is fairly early on in your medical nutrition therapy program, and anthropometry is an area that sort of underpins a lot of the things that we do in medical nutrition therapy. Starting here with the image of Michelangelo's David, one of the most famous statues ever created. And the reason that I chose this image to begin with was because it's considered a masterpiece, but one of the elements of this sculpture which is considered masterful in its nature is the body proportions, and that's effectively what we're talking about today by way of anthropometry. Now, I realise that we've never met before unless you've done my sports nutrition class in third year as an elective. So for those of you who I haven't met before, I'm a qualified dietitian and have been a qualified dietitian for over 20 years now. I worked for about 8 years at a hospital up in Brisbane, the Wesley Hospital. It's a private hospital where I spent most of my clinical time dealing with patients who were experiencing or had a diagnosis of cancer. We dealt with high-dose chemotherapy and stem cell transplantation, as well as general oncology, and I also dealt with the hemodialysis unit and the palliative care unit. So in each of these units, anthropometry is an important factor of day-to-day work. I had a fellowship at the Institute of Sport, the Australian Institute of Sport. After that sort of period of clinical experience, I'm your Bachelor of Nutrition and Dietetics Honours Program convener. So if you choose to come into the Honours Program, you'll see a bit more of me there, and there's some other professional roles. In terms of research interests, as an opportunity just to say hello to you, I'm interested in applied sports nutrition, the avoidance of hospital-acquired malnutrition through different applied and translational research programs, and we do some stuff in lifestyle nutrition as well. And here's some photos of some resources and some photos from our lab as well, talking about some of the research that we've done. But I look forward to meeting you in the workshop that's associated with today's lecture on anthropometry. So what we're going to talk about, obviously we're going to define what anthropometry is and its relevance to medical nutrition therapy, briefly talk about advantages and limitations of anthropometric techniques, we'll look at body composition, but really the focus is on what dietitians actually do in practice. And so that at the end of this module, what I would like is that you have not only an understanding of what is measured, but you also have a better understanding of how you might interpret what's measured, and then ultimately being able to collect these measures in an accurate way. So it's a little bit of understanding, a little bit of interpretation and clinical reasoning, and also a little bit of practical application by way of how do you actually collect information in an anthropometric sense and do that accurately. So we're going to be talking about how to measure, how to interpret, and how this can affect health. And then right at the end, there's a little bit of an applied activity. So let's get started. So anthropometry, as I alluded to with the statue, assesses size, proportions, and composition of the human body. Anthropometry, or the most well-used forms of anthropometry, are often quite portable. They're universally acceptable, so they're used in a range of different settings. Some can be inexpensive, others less so, so we'll talk a little bit about cost, and hopefully they're also non-invasive. They're used in interpretation of a whole range of conditions and context from birth right through to old age, and that serial nature of some of these measures can be very important. We'll show you some of that as well. Now, whilst we don't necessarily go into a great deal of information on things like whole body or restricted profile skin folds, the International Society for the Advancement of Kinanthropometry, which is ISAC by short, runs accreditation programs if you want to upskill in become accredited in measuring restricted profiles or full profiles from an anthropometric perspective. So for instance, if you worked in or were hoping to work in a sporting context or a research context where you want to get accurate measures of body composition change, then we might suggest that you do ISAC accreditation as an add-on to your degree. The type of anthropometry that we do does vary with age and the degree of the nutritional status and the sorts of conditions that you might be dealing with. It's particularly useful in circumstances where chronic imbalances in energy and protein exist, and I'll explain why it's more relevant in those contexts as we go on. And it's often limited by a time delay between poor intake and a change in anthropometry, and I'll give you a cascade of that as well. But anthropometry can be as simple as public health campaigns. This was one that was run in the last sort of 5 or 10 years, the Measure Up program, which encouraged all Australians to measure their waist circumference as an indicator of chronic disease risk. So waist circumference is another form of anthropometric measure. So where does all of this fit in? I understand that you should be starting to learn about the nutrition care process and the concept of a DIME, assessment, diagnosis, intervention, monitoring and evaluation. So in terms of assessment, we normally talk about sort of an ABCDN or an ABCD of nutrition assessment, and A standing for anthropometric measures. So it's a core element of the DIME process, and we use it in the assessment. We can also use it in the management and monitoring and evaluation of clients as well. So things like as simple as weight change is an anthropometric measure that we might use right throughout the assessment, monitoring and evaluation of an intervention that we might be running. Anthropometry starts, or at least elements of anthropometry start from when a patient arrives in a hospital facility and they go through malnutrition screening. So in Queensland, the most common malnutrition screening tool that we use is the MST, the malnutrition screening tool, and it has 2 questions. Those questions being, have you lost weight recently without trying? And the second one relates to appetite. So you can see clearly the first one, have you lost weight recently without trying? And then it quantifies that based on a body weight or a kilo weight loss. All of this is self-reported, but nonetheless it still relates to anthropometry. And we would obviously then follow this up if we had concerns with a assessment. And I also understand that you've recently gone through and had a look at subjective global assessment or patient-generated subjective global assessment. And as part of that, obviously there's some anthropometric components in that as well. Most notably weight change, which is a little bit more sort of quantified by way of looking at acute and subacute weight change. But we also, within the context of SGA, look at a physical examination, and some of that physical examination, albeit it's outside the context of things like circumferences and skin folds, we'll certainly look at or look for regions of significance where we may be able to apply anthropometric measures if we wanted to do this in a sort of more quantifiable, robust manner. And things like lean body mass, for instance, we can look for changes in lean body mass by looking at things like circumference changes relative to skin fold changes, and we'll talk a little bit about that. So the advantages with anthropometry are that most often they're simple, they're safe, they're non-invasive. Quite often the equipment is inexpensive. We'll show you some more expensive equipment as we go along. It says there that the relatively unskilled personnel can collect information. Now I would have a little bit of a question mark over that, in that anyone can take somebody's body weight, but it is important that measure is taken accurately. And when it is taken accurately, it then needs to be interpreted. And so that requires some skill and interpretation. So whilst actually getting a number on a scale is relatively easy, what that actually means and how that translates is something that requires a little bit more consideration. The methods can be precise and they can be accurate. What we mean by retrospective is that they measure effectively what's been happening with the individual, not what will happen into the future. So an anthropometric change usually relates to something or a behaviour that's been conducted and it's resulted in a physical change to the body, not necessarily what the prognosis is going to be moving forward. Mild to moderate undernutrition can be identified. It indicates changes in your nutritional state, and it can be used as a screening test, nice and quick. The limitations are that it's relatively insensitive. So what do we mean by that? Well, for instance, your global measures may be subject to some degree of day-to-day variation. And so in terms of picking up small changes, it may not be as sensitive, and we'll talk a little bit about that in a moment. It cannot detect changes in nutritional status over a short period of time. And largely, or in essence, that has got to do with the sorts of changes or the timeframes that we see in change in terms of body composition compartments. We have prediction equations for body density, body fat, fat-free mass based on young, healthy, lean Caucasian populations, and not all of the populations that we will be doing our assessments on. If we were then to convert over to body fat or use one of these generic equations relates to the individual that we may be necessarily conducting our assessment on. And the final one there says it's unable to distinguish between disturbances induced by nutrient deficiencies and those caused by imbalances in protein and energy. And so we often can't, through anthropometry alone, identify a particular nutrient deficiency, more that somebody might be on a hypocaloric diet, or that they might be on a hypocaloric hypoproteinemic diet. So I talked a little bit before about the retrospective nature of anthropometry, and that you're collecting something based on something that's happened in the past. This is a really nice cascade, if you like, of the sorts of steps that need to be undertaken before we see anthropometric changes. So you can see here that if we have stage one being a dietary inadequacy, so we've got a situation where a person's either not eating enough or they're not eating sufficiently based on their physiological need, we might be able to detect that through assessing their dietary intake. That will then lead to, more commonly, a decreased level of reserve in tissue stores, which we may be able to pick up biochemically, and possibly also a decreased level in body fluids, although many body fluids are regulated by some fairly close homeostatic mechanisms. So it can be that the tissue reserve goes down, and it goes down for a while, but the blood level is preserved until ultimately the reserve is so deplete that the body fluid levels are also deplete. We then may see a decreased functional level in the tissue, and this is probably more likely going to be picked up potentially through a biochemical assessment rather than an anthropometric assessment. Decreased activity in nutrient-dependent enzymes, a functional change, a clinical symptom, and then an anatomical change. So you can see here that there's quite a potential delay between when someone's food intake is poor relative to what we might see in their anthropometric changes. So there's a number of steps that would need to be undertaken before that anthropometric change is going to be identified. Okay, what I want to just quickly touch on now is some work that was published a number of years ago, where a survey was put out to a sort of national cohort of dietitians to actually ask them what anthropometric measures do they take routinely in their practice. And I found this paper quite useful. It's in Nutrition and Dietetics, the National Journal, if you want to look it up. And these values, or these parameters rather, were the common parameters that most dietitians reported using across a whole range of clinical practice and private practice. And so in terms of adult population, weight and weight history, height, BMI, waist circumference, hip circumference, waist to hip ratio, mid-upper arm circumference and skin folds, but particularly the tricep skin fold, so the one skin fold on the back of the arm. For those people who worked in a pediatric environment, they use growth charts around weight, height, recumbent sort of height, head circumference for age, weight and length for age, and weight for height measures. So these were the routine measures that most dietitians reported using. And for the basis of what we're looking for at this stage of your career, these are the values that I want you to be able to understand and measure and interpret and do that as accurately as possible. So our focus is going to be on these measures on this slide. Some dietitians, however, go on and measure more skin folds, so potentially through a restricted profile. So that's a restricted profile is basically a select sum of skin folds done around the body, but not necessarily every skin fold site, but a grouping of them that might be considered broadly representative of the body's subcutaneous fat. DEXA and bioelectrical impedance. And then in terms of research, DEXA, bioelectrical impedance, and air placement plasmography, which is otherwise known as things like BOD pods or P pods, which is a sort of similar concept to densitometry from in terms of traditional underwater weighing, but rather than using water, they use air density. Okay, so these measures I want you to be aware of, but we won't necessarily be spending a great deal of time delving into the actual technique of doing these. We do have a number of DEXA machines on campus, and we have a relatively new multi-frequency bioelectrical impedance device, and I'm hoping to bring that along to our workshop so we can all have a go and do some bioelectrical impedance as well, which will be a bit of fun. Whenever we talk about any anthropometric measure, though, I think there's a couple of terms which are very important to conceptualize. And the first of those relates to validity and reliability. And the easiest way to think about these is to think about it in terms of a target. So whenever we take a measure, what we're looking for is to be able to interpret that measure based on the number that gets put out before us. Now, if we take a measure, and let's say we're interested in having a look at how much body fat does this individual have, okay? Now, if we took a measure that provided results along this nature here, this first quadrant here, we can see that if this is the actual body fat value of the individual, we have a value that is not accurate. That is, that it's not over. It's not actually measuring body fat, and when it does measure on any individual basis, we're getting a high degree of scatter. So in this case, we would say that the measure that's being conducted is invalid, and unreliable. So validity relates to how accurately does this particular measure that you're taking relate to the true measure that you want to get a value for. Precision relates to how often that value is around the same value when you come back and measure it multiple times. So they're subtly different, but the concept of validity and reliability is an important one to get your head around. So in this case, we have something that's not over the target, nor is it reliable. Okay? This one here we might describe as being valid in that, broadly speaking, they cluster around the target. Okay, not many of them are right on the target, but broadly speaking, the distribution is over that area. But it's unreliable in the fact that they're scattered, and they're broadly scattered. In this case, we have no validity, but high reliability. So it's not measuring what we want, but when used repeatedly, it's providing a measure that's quite precise or quite reliable. Ideally, and ultimately what we want, is something that's both reliable and valid. So if we look at this in terms of examples, before we go on to that, I'll go to error in a moment. Let's have a look at some examples. So this first device here is an infrared skin detector for determining subcutaneous fat. And we know that value that comes from that machine is not representative of the subcutaneous fat proportion of an individual. So this would go on one site and measure, and it would give you a value, and that value would vary from time to time, and we knew that it wasn't representative of the total body fat, which was what we were interested in. Another example of an anthropometric measure might be skin folds. Now, when you measure somebody's skin fold, you are actually measuring something that is a valid measure. There are some assumptions in that when you're measuring the subcutaneous fat, that is also representative of the central fat the fat around organs in the core components of the body, which we're not measuring. But you are, by way of actually taking the measure, measuring the subcutaneous fat at that site. Now, depending on who's taking the measure and what their technique is like, their reliability could be quite poor. So it is, irrespective of who's taking the measure, a valid measure, but if the person's not well trained and they're not taking or identifying the correct sites, then their reliability and their precision is going to be poor. If we look at something that might be precise but not valid, we might consider some blood measures. For instance, if we look at the calcium in someone's blood, we know that your blood calcium level is not representative of your body's total calcium store. Most of the calcium in your body is stored in your bones, and your blood calcium level is closely regulated. So you could have low bone mineral density, but your blood calcium is still the same value when we measure it multiple times. And it might be within the reference range. But we know that it doesn't really matter how many times you measure blood calcium, it's never going to give you the value for bone mineral density. So it's invalid, but it's precise in that when you measure blood calcium from one sample and you did repeated values of that, you would probably get very, very consistent calcium values. So it's never going to be valid, but it is quite reliable. Now, ultimately, what we would like is something, as I said, that's reliable and valid. And if we use the example again of skin folds, here we've now got something that's valid. The validity hasn't changed because the technique is still the same, but we've got somebody now applying the technique who is well trained and well experienced, and they're doing things in a very systematic way. They're well managed, and now all of a sudden the value becomes more precise. Another example here might be DEXA, which will give you a value potentially of body proportions, and it will do it reasonably accurately from one test to the next. That's the concept of validity and reliability. Now, we also talk about error. We talk about random error and systematic error. So a random error is an error that gets introduced into the assessment, which is not subject to a particular bias. So it comes and goes in different magnitudes and in different frequencies. So it occurs randomly within the test. So an example of this might be if you're taking somebody's weight and you pay no attention at all to what clothing they're wearing when they're coming into your clinic and they're having their body mass taken. And on one occasion they've got boots on another occasion they take their boots off, on one occasion they've just eaten, another occasion they're wearing a heavy jacket. You'll have a series of weights, but you've introduced an error which you can't correct for because you weren't systematic in terms of that error being introduced. A systematic error by definition is more consistent, and the example of that might be that your scales are not calibrated, for instance. So if they read 2 kilos heavier every time somebody hops on the scale, even retrospectively, if you put a standardized weight on there and realized that your scales were not correctly calibrated, you could correct for that error in all of your measures by making that 2 kilo adjustment. So a systematic error is much easier to account for than a random error, but we're trying to reduce both forms of error as much as possible when we take anthropometric measures. Okay, we might have a quick pause there and we'll start part 2 looking at reliability and validity of body weight.